webinar on Medicare coverage of home health services. Today's webinar will be presented by Center for Medicare Advocacy Associate Director Kathy Holt and Senior Attorney Wey-Wey Kwok. Excuse me. The Center, as many of you know, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage and quality health care for older people and people with disabilities. Founded in 1986, the Center focuses on the needs of people with longer-term and chronic conditions. The organization's work includes legal assistance, advocacy, education, analysis, policy initiatives, and litigation of importance to Medicare beneficiaries nationwide. And our systemic advocacy is based on the experiences of the real people like you who contact the Center every day. Now, before I hand things over to our presenters, I need to take my usual obligatory few minutes of our time to do a little housekeeping regarding this GoToWebinar system that we're using for our presentation today. If you can hear me, great. You use the information in the email you received after registering to successfully log into our webinar, and you've either dialed in by phone or you've got good quality working speakers on your computer, either of which will work for you today. As is the case with everything nowadays, audio quality is very much going to be at the whim of your hardware and internet connection if you're using that computer audio. So do remember that if you have issues, you can always dial in by phone to the number that's provided on that confirmation email you got, which should also appear under the tab on the control panel that you see called Audio. A little bit more about that control panel that I hope everybody sees. There are a couple key features for our use today. Note the buttons on the tab at the left side of the panel. There's a little orange arrow. That'll let you hide the panel so it's not in your way. There's a little square. That'll let you watch our presentation in full screen view. And there's a little picture of a hand. It's my favorite. The hand icon will be used to indicate that you have a question. During the presentation, we're going to keep attendees muted because we have an extraordinary number of people joining us today. But when we stop for questions, you can use that little hand icon to indicate you have a question. And if we get to you, I can unmute you at that point. Now, if we don't get to your questions live, and that's a pretty good possibility given the numbers that we're looking at here, we also have a section in that control panel labeled questions. A few people have already discovered it, I can see. You can hit the little white triangle at the left side of the section labeled questions, and it opens up a little box. And in that box, you can type your questions as they come to mind. I encourage you to do that, regardless of whether you think you're going to ask one live or not, because that way they're in the system, we can see them, I can pass them on to our presenters as we get to them. And as a little bonus, we are going to review some of the questions after the fact, see if we see any patterns that we might be able to address sort of en masse. So I encourage you, as questions pop into your head, pop those into the questions control panel. Finally, you all should have received a copy of the slides for today's presentation, as well as a copy of our recent home health survey report at the email address that you used to register. If for some reason those didn't make it, there's a typo in the address, something like that, those are available right now in that control panel in the section labeled Handouts. It says Handouts 2 of 5. You can open it up, click on the PDF, and download it right now. I want to thank you all for attending today, and I will now hand things over to Center for Medicare Advocacy Senior Attorney Wey-Wey Kwok to really get us going. Wey?
Hey, thank you. Hi there. Hello, everyone. So I'm going to breeze through the agenda just to let you know what's in store. So I'm going to be reviewing the Medicare home health coverage criteria. And my colleague, Kathleen Holt, will be addressing obstacles to accessing covered care and also going through a case study that will illustrate some of those obstacles. And then we're actually going to move up the questions and discussions portion of the presentation to right after the case study, because we do want to hear from folks. And then hopefully be able to touch on practical tips and resources in that discussion. Next slide, please. So yes, the Medicare home health benefit importantly allows homebound individuals to obtain medically necessary health services in their place of residence. For several years now, the Center for Medicare Advocacy has been concerned about the increasing reports of beneficiaries being unable to access the types and amount of home care they need and for which they are eligible. In many instances, these are people with chronic, disabling, and sometimes complex medical conditions who are being denied care based on inaccurate or misleading information about Medicare coverage. So today I will go over the services and items that are included in the home health benefit and explain the eligibility requirements for coverage. The information I provide will be based on the statute, regulations, and Medicare's policy guidance. Next slide, please. So this slide shows the 3 general requirements to qualify for home health coverage. First, the person must be under the care of a physician or an allowed practitioner who certifies their eligibility and establishes and orders a plan of care for home health services. And that plan of care must be reviewed by the physician at least every 60 days. Secondly, the person must be confined to the home, or more specifically, meet the agency's definition of homebound, which I'll discuss in more depth shortly. Now, home is anywhere the person lives. It could be her own or a relative's dwelling. Home can include an assisted living facility or a group home that is not primarily engaged in providing skilled medical services. The third eligibility requirement is that the person must need a skilled service that is medically reasonable and necessary to treat their illness or injury. The skilled service must be ordered in the home health plan of care. So these are the 3 qualifying criteria that trigger coverage under the benefit. Now, there are additional technical requirements that the home health provider must meet in order to get paid by Medicare. In submitting a claim for payment, the home health company has to show that the patient has actually been examined by a physician during what is called a face-to-face encounter that is related to the reason why the patient needs skilled home health services. The the provider must also ensure that the physician who orders the services properly certifies and supports with medical documentation why they believe that the patient is homebound and needs skilled care. Next slide, please. So if the individual meets the 3 criteria on the last slide, then they qualify for coverage of home health services. So what are those services? So we know that the patient must need a skilled service at home, and this will either be intermittent skilled nursing, physical or speech therapy, or continuing occupational therapy. Now, if they are receiving at least one of these skilled services, then they are also eligible for coverage of dependent services needed in relation to their illness or injury. Dependent services can include home health aides to provide hands-on personal care, medical social worker services, and medical supplies. Now, the plan of care has to include specific orders for these services. Next slide, please. So it's important to know that there is no time limit or cap on how long someone can be eligible for home health benefits. As long as the person needs a qualifying skilled service and meets the other threshold criteria, then coverage can continue to be available. Now, if someone is being told that this is just a short-term benefit or that Medicare only covers a certain number of days of home health, that is plainly false. Next slide. Okay, so let's look at the homebound requirement more closely. To be considered homebound by Medicare, a person must meet a 2-prong requirement. For the first prong, the patient must either, because of an illness or injury, need the aid or of a supportive device like a cane, a walker, or wheelchair, or special transportation, or the assistance of another person in order to leave their home. Now, understand that one could need the assistance of another person because of physical limitations or because of cognitive or mental limitations. Alternatively, the person could have a condition such that leaving home is medically contraindicated. An example would be, someone who is severely immunocompromised or whose heart condition is so severe that the doctors told them to avoid all physical activity. Under the second prong, there are two additional requirements. First, there must exist a normal inability to leave one's home. The agency has never expressly defined what a normal inability means, but the guidance suggests that the requirement would not be met if someone is leaving home on a frequent or regular basis or for long periods of time for non-medical reasons. Okay, the second requirement here is that leaving home must entail a considerable and taxing effort due to the patient's condition. Next slide, please. So Medicare has clarified that certain absences from home would not, by themselves, disqualify someone from being considered homebound. So specifically, you can leave the home for the purpose of obtaining health care, and this includes medical appointments or receiving therapy that isn't available at home because it requires special equipment or technology. Attending adult daycare for the purpose of therapeutic, psychosocial, or medical treatment also counts as health care. But it would need to be in a structured setting of a licensed and certified or accredited adult daycare program, as opposed to like an informal drop-in program at a senior center. Under Medicare policy, infrequent or short absences from home are also allowed, and this includes attending religious services, attending unique events like a family reunion, funeral, graduation, occasional walks around the block or trips to the barber, likewise would not disqualify someone. Next slide, please. So it's valuable to take a deeper look at a person's outings, because agencies often miss the true nature and difficulty of those outings. So for instance, agencies often conclude that someone is not homebound because they regularly visit relatives. But on closer examination, we might find that an adult child is really bringing their parent to stay at their home each weekend to provide necessary care and companionship. Now, the policy, Medicare's policy, says that you can split time between two residences, your own and a relative's home, or even a vacation home, so long as you meet the homebound criteria in both locations. Agencies sometimes conclude that a person is not homebound if they can operate an electric wheelchair or power scooter. And this, again, ignores the considerable and taxing effort or assistance it might entail for them to prepare for the outing or to transfer in and out of their wheelchair and also navigate outside of the home. So, the agency still has to consider if the person's outings are short, infrequent, or for medical purposes. Now, I would argue that, a weekly grocery shopping trip in a scooter should not disqualify someone. As food is essential, and grocery shopping is arguably, relatively short and infrequent. Let's see. Agencies also sometimes neglect to consider a person's visual deficits, their cognitive status, pain levels, respiratory status, or endurance. And these are all issues that could make leaving home very taxing and even unsafe. So let's see. The fact that a beneficiary can drive does not by itself mean that they can't be homebound. And they might still satisfy each of the criteria in those two prongs I talked about. But overall, we should be looking at a larger picture of the person's condition and experience. Next slide, please. Okay, so let's shift now to the skilled service requirement. For Medicare home health coverage to begin, the patient has to need a skilled service, and that triggering skilled service can either be intermittent skilled nursing services or skilled physical therapy or speech language pathology services. Well, what about occupational therapy in the home? The rule is that skilled occupational therapy cannot be used to initiate coverage. But if the person needs skilled occupational therapy along with another skilled service and that other skilled service ends at some point, they can continue to qualify for coverage with occupational therapy. Next slide, please. So what is the standard for skilled services? In determining whether the particular service a person needs is skilled, Medicare considers the inherent complexity of the service and whether it can be performed safely and or effectively only by or under the general supervision of qualified personnel. Now, in order to be covered, the service also has to be medically reasonable and necessary, based on an individualized assessment of the patient's clinical condition to either treat the patient's illness or injury, or skilled nursing can be needed to maintain the patient's current condition or prevent or slow further deterioration. Similarly, therapy services could be medically reasonable and necessary, not only to restore a patient's function that has been impaired by illness or injury, but also to maintain the patient's function, even if restoration is not possible. Next slide. So I want to talk a little more about this. Some of you may know that the Center for Medicare Advocacy represented a beneficiary and a group of national organizations in a lawsuit called Jimmo versus Sibelius. The settlement in that case reinforced and clarified that a patient's restoration potential is not the deciding factor in whether Medicare coverage is available, and that even if full recovery is not possible, a patient may need skilled services to prevent deterioration or preserve current capabilities. So in short, improvement is not required for service to be considered skilled or reasonable and necessary. Next slide, please. Okay, let's talk about skilled nursing. Now, the statute requires visiting nurse services to be intermittent or part-time. What does this mean? Well, this means that nursing visits must be provided on a less than daily basis, but at least once every 60 days. A nursing service could be covered when it's provided less frequently than 60 days, but there would have to be a predictable recurring need for the service. An example is a person who might need a medication injected intramuscularly every 90 days. Or if someone has a predictable recurring need for a nurse to perform bowel disimpaction, that could be covered, even though you might not be able to pinpoint exactly when the person might need that service. Now, sometimes a beneficiary will require daily nursing services. An example is, for wound care. The home health benefit will cover daily visits for up to 21 days, with extensions in exceptional circumstances. But the patient's physician must affirm that the need for additional daily care is finite and predictable. Next slide, please. Okay, there is an exception in that Medicare will cover, without limitation, daily nursing visits to administer insulin injections to someone who cannot self-inject, and if there's no other person willing or able to administer their insulin. Now, this may be the case for someone who lacks the fine coordination, visual, or mental ability to inject their own insulin. Next slide, please. The regulations define specific skilled nursing services that can be covered. So a doctor may order nursing visits to observe and assess the patient at home. And this is a covered skilled service when there's a reasonable potential for change in the patient's condition, and the nurse's skill and judgment is needed to evaluate whether the patient is responding to the current treatment or if further intervention is going to be necessary. Visiting nurse Nurses can also be ordered to provide patient education services. And this is basically teaching or training to the patient, family, or caregivers on how to manage the treatment regimen. This can be covered for a reasonable period of time, and reteaching and retraining may be appropriate in some cases. Now, nursing visits might also be medically reasonable and necessary to manage and evaluate a patient's care plan if the patient requires skilled oversight of unskilled services they're receiving. Now, this might come in play with a patient who is medically fragile or who has an underlying condition that heightens their risk of complications. So there may be complexities to delivering essential unskilled care to them. Now, when ordering this type of nursing oversight, the physician must include a narrative explaining why the patient needs this type of service. Now, the regulation recognizes that certain types of nursing services are by nature skilled, and this includes intravenous or intramuscular injections, intravenous IV or enteral feeding, suprapubic catheter care, wound care, and treatment of extensive decubiti. Those are just some examples. Next slide, please. So skilled therapy is covered if there is either an expectation that the patient's condition will improve materially, or the unique clinical condition of the patient requires specialized skills, knowledge, and judgment of a qualified therapy professional to design or establish or perform a safe and effective maintenance program required in connection with the patient's specific illness or injury. So again, the goal of therapy can be maintenance. And now the benefit also covers maintenance therapy that is performed by a therapy assistant. Okay, next slide. So this slide contains really an important policy statement. Medicare expressly states that in deciding whether someone needs skilled care, their overall medical condition should be considered without regard to whether their illness injury is acute, chronic, terminal, or expected to extend over a long period of time. Moreover, the patient's diagnosis should never be the sole factor in deciding if they need skilled services. So the policy recognizes that skilled care could continue to be necessary even for patients whose condition is stable. Next slide. Okay, so moving on to dependent services. Now, to refresh your memory, if someone is receiving at least one qualifying skilled service, then coverage is also available for dependent services that they may need in relation to their illness or injury, such as home health aides or medical supplies like colostomy equipment, catheter supplies, or also medical social services. Now, the type or amount of skilled services someone receives does not determine the amount of dependent services they can receive. So it's incorrect and improper for a home care agency to say to someone, well, because a nurse is only visiting once a month to change your catheter, well, Medicare won't cover any aid services, or will only cover one aid service per week. Or, oh, Medicare doesn't cover aid services if you're getting therapy. It just doesn't work that way. Next slide, please. So home health aid services, how much can be covered under the law? So under the statute and regulations, aid services combined with skilled nursing services can be covered up to 28 hours per week and any number of days per week, but they must be provided less than 8 hours on any given day. In certain situations, subject to review on a case-by-case basis, coverage can actually be available for up to 35 hours per week of combined nursing and aid services. So as you can see, quite considerable coverage is available under the law for home health aid services. Next slide. In reality, unfortunately, we rarely, if ever, hear about people who get anywhere close to that level of aid service from a home care agency, even though the law expressly covers it. So in practice, beneficiaries are often told by home care agencies that Medicare will only cover maybe 1 to 3 hours per week of aid service, if that much, and that the aid is only available to provide assistance with bathing. So agencies often say that they do not have the staff to provide many or sometimes any aid hours or visits to someone. And we do hear about agencies suggesting that families find a private pay alternative for the aid services that the patient needs. Next slide. So, however, okay, so under the benefit, home health aid services that are coverable must be to provide hands-on personal care to the person. Now, if someone only needs homemaker services, that would not be covered. But services like light housekeeping, meal prep, or simple errands can be covered if they are provided incident to the hands-on personal care that the patient needs and that the aid is furnishing. Now, beneficiaries are sometimes told that they cannot get aid services because aid services are not skilled. They're custodial care, which Medicare doesn't cover. Now, that's a false claim. The statute establishes that home health aid services are covered under the home health benefit. Next slide. Okay, so the regulations define hands-on personal care, and they define it as much more than just assistance with bathing. Covered home health aid services can include assistance with dressing, grooming, hair and nail care, oral hygiene, changing of bed linens, assistance with feeding, elimination, routine catheter and colostomy care, skin, foot, ear care, help with bed mobility and transfers, ambulation, medication assistance, and also simple dressing changes for wounds or other skin issues. Next slide, please. So we are definitely seeing a trend in patients receiving less and less home care services, and particularly aid services. And this is especially so if the patient lives with a spouse or other family member. And it seems that agencies are presuming that having another family member around means that they're getting their needs met from that person. And I think that is that even having that presumption is wrong and not supported by CMS policy. So what I have on this slide is actual, from the policy manual. It says that patient is entitled to have the cost of reasonable and necessary services reimbursed by Medicare without regard to whether there is someone available to furnish the services. But where someone is or will be providing services that adequately meets the patient's needs, it is not reasonable and necessary for the home health agency to furnish those services. But it goes on, the policy goes on to state that there is a presumption that there is no able and willing person at home to provide the services unless the patient or family indicates otherwise, or the home health agency has firsthand knowledge to the contrary. So I think it's really important here to look at, having knowledge of whether this patient has someone who can adequately meet the patient's needs. And I think it requires a conversation with the family, an honest conversation with the patient and their family, because sometimes you might have people in your life, but they might not be around all day. They might not have. They might have their own health issues that make it difficult for them to safely provide the services that you need, that the person needs. So that's the consideration there. And with that, I will sign off and let Kathy join and provide more information about obstacles in receiving care.
I think you're muted, Kathy.
I am. Too many buttons to push. Thank you, Wey-Wey, so much for your wonderful kind of laying out of the coverage that Medicare provides for under the law. It's very important to understand what you should be entitled to. But then the next question really becomes, why is it that there is a disconnect, if you will, between what Medicare is able to cover under the law and what people are able to access? So I want to go through some of those, the issues that we've uncovered in our work at the Center for Medicare Advocacy, and that we have learned so much from so many of you on this webinar today, in terms of your firsthand knowledge of the frustration of getting those services. Look at a particular case study that we have of an individual we were able to help, and the process that we went through in order to do that, and then spend as much time as possible opening it up to questions and a discussion, and leaving the rest of this presentation that we have regarding tips, advocacy, information, resources for you to take forward. So why is this happening? As I mentioned, there's a disconnect. There's the law versus reality. And as Wey-Wey mentioned so clearly in her articulation of the coverage, legally covered services are often not available in reality for people who qualify. So one of the big reasons for that is that home health agencies are not required to take every patient. There are a number of reasons for that. The biggest one really has to do with staffing. And I will say that all of these issues predate COVID. So while COVID has exacerbated the problem with staffing, this is an issue that needs to be addressed in a way that that is more systemic and is more long-reaching. CMS policies, payments, and practices don't help to implement the coverage law for everyone. There are certain types of patients that typically with shorter term and post-acute care needs who are able to get services. They've had a knee replacement, they've had a hip replacement, and what happens is they go into treatment, therapy, home health nursing for a very short period of time, and then recover and move on. The benefit that's more difficult to receive is for those who have chronic and longer term conditions, which is one of the reasons why we brought the Jimmo case, is to shine a light on the fact that people who have chronic and longer term conditions are equally coverable by Medicare when they meet the criteria. So in particular, our concern has focused on this access to home health aides. And we noticed that it's very difficult, as you could see from the survey that was sent along with these slides to you today. You could see the difficulties that we've had when we made calls to over 200 agencies and found that access to home health aides has diminished significantly. And it's important because we know that the use of home health aides is oftentimes what means the difference between keeping people in their homes and allowing them to stay at home and having to abandon their homes and to be institutionalized. So we really are focusing very specifically on what's been happening with the home health aides. So why is this happening? The Medicare payment systems pay very much highly weighted payments on the first 30 days of care, which is difficult if you have a chronic condition and you need services for an extended period of time, certainly longer than 30 days. There are quality measures and home health value-based purchasing measures. Those particular policies are geared highly for criteria of improving a patient. And if you're not able to improve because you have a chronic longer-term condition, then these policies disfavor you. Audits by Medicare contractors in the Office of the Inspector General. One of the things that intimidates home health agencies from being able to serve patients is the fact that these audits are targeted toward intense resource using type patients or longer term patients. Why do you have a patient on service for so long? And agencies want to avoid these audits and targets by the contractors. So again, we hear stories from all over the country about these access problems, and we're trying to make sure that you understand what the coverage should be and try to find it, because there are agencies out there that do provide more services than others, and it could be very much based on the amount of staffing that they have at a particular point in time. But it's important to also understand where these statistics are coming from and why we are so alarmed by the way that the benefit is moving forward and has been, frankly, over the last 20 years. So if we look back to Medicare coverage, which hasn't changed over the last 20 years, we see that home health aides as a percentage of the total visits was 48%, and now it's down to less than 6%. So there's something wrong with the system that doesn't change the rules, but then the amount of services that are available are diminished so significantly. MedPAC, which is the Medicare Payment Advisory Commission, refers to efficient providers in the home health arena that made almost 24% profit on traditional Medicare patients. In the last report that was put out of 2019. What's important to realize about that is that the term efficient provider typically means the provider is providing less services to the patient and pocketing more profit. So it's important that when a patient is receiving services, they understand how the payment works with Medicare home health. The providers are given what's known as a prospective payment. Before the services are even delivered, there is a formula based on the diagnosis and the amount of comorbidities and the functional impairment and the length of time in service. It's a formula that takes into account those criteria and then says, we're going to give you $3,000 for 30 days. And whatever you want to do with that $3,000, you have to report the services that you provide. But once you provide a minimum number of services, then you can keep all the rest of the money. That's a really kind of a shorthand delivery. There's a lot more detail that go into it. But the point that I'm trying to make is that you should not have a payment system that rewards providers and calls them efficient when they're providing less and less services and making more and more profit. The auditors have said that improper Medicare payments have declined from 59% to 9%. The point of this statistic that I want to make is that we need to make sure that everyone really understands what improper payments are, because oftentimes providers, home health providers, home health agencies are penalized from the standpoint that they may be serving someone who is audited as not being homebound when they really are homebound. So there's a lot of information that goes into these statistics that leads us to believe that the system needs to be changed. We have to identify what the problems are and understand what you're facing in order to figure out how to deliver more services to people who deserve them and need them. So again, here are some just reports based on those quality measures that I talked about, the criteria that rewards improvement, the payment system that shows that upwards of 40% decline in payment after the first 30 days of services, and then these audits that are often based on incorrect standards and a misunderstanding of the coverage laws that Wey-Wey just went through. So just briefly to go through a case example, because I really do want to get to questions and discussion. This was a wonderful family that we helped change the name for purposes of anonymity. But Mr. So had ALS, and he needed all types of services that were provided through home health care. After 6 weeks of receiving home health care, the home health agency said, well, Medicare requires us to leave you for 60 days. Then we can come back and see how you are. So what happened in this case is they did not consult the doctor. They ended the home health agency ended the care and said, we'll come back and see how you are. Unfortunately, because he didn't have those therapy services and nursing services, Mr. So declined rapidly over the 60 days that the home health agency had left them. And all of the services, again, were restarted. And at that point, the agency said, well, we can only be here for 6 weeks. So the agency refused to show the patient and the family the plan of care when the patient and the family requested, wanted to be part of the process, wanted to understand what was the documentation that was going in, wanted to make sure that it was correct because they had availed themselves of understanding what they should have for coverage. The physical therapist just stated, well, there's no point in providing physical therapy because this individual is just going to lose muscle mass anyway. So why try to slow it or prevent it in any potential way? So you can see this case is unfolding where there's a lot of issues happening that have to be addressed, kind of one after the other. At this point, the doctor was ordering aids 2 times a day, again, covered by Medicare, but the agency was providing a bath every 2 weeks. And the agency said they had 1 aide on staff for 500 cases. But we could tell that this agency was such, they were strong. They were actually affiliated with a large hospital. And they were bringing in more than $16 million in annual Medicare revenue. So we thought this is very wrong if they only have 1 aide for 500 cases. But the agency did have a private pay department for aid services where you could go and pay privately. So you could get some of your skilled services through Medicare, but then you could go do the private pay. So what happened to this case? After the advocacy, the agency was educated, the home health agency was educated, the areas of the hospital were educated, and we ended up reaching, mostly through the family's advocacy, a promise to deliver more services and for the remainder of this man's life. So let's do a quick analysis of this case example. As long as the patient qualifies, and this is really a reiteration of everything that Wey-Wey went through with you. As long as the patient qualifies, the home health care can continue. There's no cap, there's no limit on service. So as the agency finally agreed with us, they would provide services for this individual for the rest of his life. The discharge should never happen without the doctor's agreement under the Medicare conditions of participation. There are certain rules, and they are in the materials that follow here, called the conditions of participation. That means that if an agency is going to participate in the Medicare program, they have certain credentialing, certain rules that they are required by Medicare to follow. Included in that conditions of participation is something called the Patient Bill of Rights. That Bill of Rights requires the patient to be provided with a plan of care when they request it under the conditions of participation. Very rarely do I talk to a family who is trying to get home health care who's actually seen and signed off on and understood exactly what is in the specific plan of care that is typically between the doctor and the home health agency. But it's very important that the patient be proactive and aware of what that plan of care contains. Medicare covers physical therapy to help maintain or slow decline of function, despite the physical therapist or the agency determining there's no point. This is something that we are really pushing to get this concept of maintenance and also to stop the decline, to slow the decline of deterioration in a person's condition. The home health agency has to provide all the services as ordered or arrange for services, although orders are sometimes changed after agency assessments. And to this, I would say the more specificity that you could have the doctor or the authorizing practitioner who's ordering the care to put into that order and plan of care, the more the home health agency will be able to assess and properly understand what the needs of the patient are. Shifting aid services to a related private pay division allows home health agencies, again, to get the full Medicare reimbursement, which is intended to include up to 35 hours of aid services, as Wey-Wey went through, plus the private pay reimbursement generated for the related division. One would think that this is an illegal practice. Unfortunately, it's not. And so there are ways that we are trying to address this, particularly to make sure that that when this practice is done, that CMS is aware that it's happening. And certainly advocacy to obtain more services and for a longer period of time. And I can't say enough about the family involvement in this case and how they contacted the agency and really fought for this home health care to be delivered regularly, consistently, and with more of the services that this individual needed. Okay, so Matt, how about I turn it back over to you? We'll bring Wey-Wey back in, and we want to hear from everybody about what you're experiencing and how we can shed some light on that and how we all collectively can make this better.
No, there's no questions. Just kidding. Just kidding. There's more questions than I've ever seen for any of our webinars. We have a few people with hands up. Some of these hands have been up a while, so I'm not entirely sure if they really have a question or just accidentally hit the hand button. Let me say, when I do call on you, I'll call on you by first name. You are probably muted at your end. You will click your microphone one time to let us know whether you really had a question or whether you just hit something accidentally. So I'm going to call on Leighton. You had your hand up from the get-go. Leighton C., who is self-muted. One click on your microphone. Or you didn't really have a question? Guess we'll go with that. All right, let's try V. Ann. Did you have a question? These are some of those long-term hands. All right, we'll go with no on that one too. How about, sorry, Carolyn, I think I saw your hand up. Carolyn G., you are self-muted. One click on your mic. There you go.
Hi.
Hi.
I have a good friend that has Parkinson's, and it's getting more into the advanced stages, and she's was discharged from the hospital to a post-acute rehab facility that keeps setting various dates for her discharge to home, but she cannot be cared for at home without help. Her husband is older and can't do lifting and etc. to help her get in and out of bed and onto the toilet and stuff. So we are her friends. We're trying to figure out how to bring her home safely, but it almost seems like she's going to require 24/7 care because she's getting up in the night, wandering around. Has started to have some delusions or hallucinations. So any suggestions on how we can get her the care she needs?
So I'll start, and then Wey-Wey, you can pop in. The first thing that I would do in that situation is check with the facility that she's currently in to see if they have social work services, they have some type of discharge planning that she might be, that you could avail yourself of. They would certainly be in a better position to understand what services are available in the community, and to be able to look at what the alternatives are. The Medicare home health care program in and of itself is not intended to be a 24/7 type of a coverage. So there may be some services available, but there would have to be some coordination with other services as well.
Okay, thank you.
Thank you very much. Kenneth? You are self-muted. One click on the mic. There we go.
As a Medicare beneficiary counselor, I handle a couple of cases at present and in the past where they are dealing with a Medicare Advantage plan. Now, I apologize, I came in late due to handling some cases. And if you've covered it, then I'll review the material when we get it available to us. But for right now, the question is, do the things that both Wey-Wey and the subsequent person talked about, are these applicable only to Medicare, original Medicare, or do they also apply to the Medicare Advantage plans that have signed contracts with Medicare?
That's a great question. The answer is that the Medicare Advantage plans are required to provide the same coverage or more coverage than what is covered under traditional Medicare. So there is a regulation that specifically states that all Medicare Part A and B services, which includes home health care, must be provided to the same extent as in traditional Medicare. Medicare Advantage plans have networks, and so oftentimes there are less choice available to people because not as many home health agencies may participate in a network. So it's important to contact the Medicare Advantage plan to find out which home health agencies are in their network. And I would say if there's you exhaust the services that are offered within the network and you're not able to get the services that you would need, I would go back to the Medicare Advantage plan and inform them that the law says that they are required to provide these services, and if the network isn't adequate enough to do that, that they must make arrangements with a non-network home health agency to provide the services.
And if I may, a subsequent question to that. Therefore, if they can't provide the services and they are required to provide it from a non-network, then the charge or the cost has to be an in-network charge because they could not provide the in-network service. Am I correct in that understanding?
Theoretically, that's true. I would say that one of the obstacles that Medicare Advantage plans put in front of people that traditional Medicare doesn't do is prior authorization for services. So this may kind of be beside the point of what you're asking, but I think it's an important point to make, that we see oftentimes the feedback that we get from home health agencies is that they are authorized to provide less services than traditional Medicare because they are going through some kind of a prior authorization. This is what we think, we being the Medicare Advantage plan, thinks that you need. So that's just again another obstacle, if you will, or something to be careful of when you're in a Medicare Advantage plan.
My last part of that question, and I'll mute, is if I need further explanation beyond what you've given and specific to my cases, does the Center for Medicare Advocacy accept letters and emails so that they can provide further rules and regulations that pertain to these cases?
Yeah, so to that point, I would say we have extensive resources on our website. We have a lot of self-help materials. We have a lot of writings that we've done on these issues, including tips and practical solutions, if you will. But you can certainly ask us specific questions. We're limited in our resources in that we can't help everybody who asks us for services just based on the fact that we have a lot of work to do and not a lot of people to do it. We're lean but mean. So so certainly always through the communications email address that you registered at this. Matt can share that with you as well. But we're always happy to try to help in any way that we can.
Yes, and I would also mention if you do a lot of work in Medicare, we have this excellent Medicare handbook that we write, and it's a treasure trove for advocates who are doing Medicare work.
How is that available to me as a SHIP counselor through the resource center of the website?
Yes, I believe so.
The introductory chapter is available through the SHIP TA Center. And then we have more information about the book itself on our website.
Then I can request or download a copy of it, or through the center.
So it's a purchase for the book
Yes.
itself.
Very good.
But there is some parts of that are available through the TA Center.
All right, so I can make the purchase of the book through the center.
Correct.
Thank you very much for your time and your information.
Thank you, Kenneth. Let's try Patty. I think you are one of those long-term hands. Are you there, Patty? Patty F. Nope. Okay. Let's try Ann P. Do you have a question for us, Ann?
Yes, my husband has Parkinson's and it's advancing. He did have some physical therapists coming in for a while because he also had a bout with pneumonia and sepsis. But then that has ended. And I can tell he needs to have something on a regular basis, physical therapy to keep his muscles working. And I'm wondering, how can I get this started? Is my first step to talk to his doctor to request this? I'm just not sure how to begin it.
Sure. Yes, the doctor would write the order for the services that he needs. And then we always first recommend that the patient ask the ordering physician or authorized practitioner if they have any recommendations of home health agencies that they've heard of, that they've used, either the person themselves or the staff in their office. The next part of that alternative, if there is no kind of good direction for that, is to take the order, and I can walk you through a step that helps people find home health agencies. And if you go to the Medicare.gov website, so Medicare's website, and you ask for Care Compare in the search bar, then you'll get a screen that shows you a hospital, a home health, skilled nursing facility, the icons, and you click on the home health icon, and then you put in your zip code. When you put in your zip code, it will provide you with all of the Medicare certified home health agencies that serve your particular zip code. And oftentimes, as we have seen from the survey that we did, you can call one home health agency in your zip code and get completely different information about what they're able to provide as far as services go. So it's often, we often recommend that people contact a number of home health agencies, tell them that you have an order for services and that you need them, you would like them to come do an assessment for services, and then they will make those arrangements.
Okay, great. Thank you.
Thanks, Anne. I see we're at 3. We have oodles and oodles of hands still up, oodles of questions written in. I'm going to suggest those of you with your hands up, maybe write in your questions. We probably will not be getting to everybody. Let's take a few more until our presenters have to go. I will keep them on here because this interest is incredible. Marty M., are you there? One click on your microphone icon.
Did you
There
say
you go.
Martha? Okay, go ahead.
Yep. Go ahead. Ma'am?
Martha Mead, is that correct?
Yes.
Okay, I'm sorry. Yes, I've been on board of directors for an organization that helps people with quadriplegia to live at home. And the previous person that raised her hand asked about where to begin, and you did not mention IHSS, and I was wondering, is that separate from the Medicare program?
I am not familiar with that. Wey-Wey, do you know anything about that?
Now, could you?
Yes, in-home health services is the government agency that provides so many hours of attendant care. And if that's the case, I am learning that there is additional funding then through you, because people are limited to 40 hours a month of getting attendant care. So IHSS is where I would recommend that person whose friend has Parkinson, she needs to discuss that with her social worker. But what I'm learning again is that these questions that you are answering is going to be able to provide our clients with additional help that they need. So I thank you.
And to that point, I think I would add, I'm not familiar with that particular program, but many states through their area agency on aging have various programs that are not Medicare related, but they are set up to help. So it's oftentimes important for people to contact their senior centers or their area agency on aging, their regional offices, to see if there are other programs available. I'm familiar with a couple that help different types of people with longer term conditions. So there are definitely more resources out there. So thank you for bringing that.
Okay, thank you very much.
Thank you. James, you had your hand up for a while. James D.
Yes, can you hear me now?
You're a little faint.
Okay, my question is this. You can only receive up to 8 hours a day or 28 to 35 hours per week under traditional Medicare or Medicare Advantage plans. Is that correct? And is there any discussion on the recertification period? You have to do it every 60 days. And there's nothing that dramatically changes for chronically injured or ill people in 60 days. It's redundant, it's unnecessary, it's cumbersome, and it's a tripwire that you have to fight every 60 days. Is there any discussion about changing that around and extending that semi-annually or annually?
Okay, in answer to your first question, yes, it is. the limit is up to 8 hours per day and only 28 to 35 in exceptional services circumstances hours per week of combined nursing or aid. And to answer your second question, yes, understood that this, you know, 60-day episodes do present problems for people who need continued care over, you know, over a longer term. I don't know, and maybe Kathy can provide input, you know, whether there's been any movement to try to change that. We think the changes have been even to make the episodes, the inquiry even shorter than that, so.
Yeah, the majority of cases are shorter. And so part of this is looking at that 60 days. One of the things, as Wey-Wey talked about, the face-to-face requirement is not required every 60 days. So that in and of itself at least stops the necessity to go through that particular hoop or that particular step. The certification is more of a let's touch base and make sure that all of the services that are being provided are being ordered, are being provided. And so it's a bit of a check and a balance. And it also is a justification for the continued need for service. And when someone clearly has a condition that's not going to get better and that's going to be chronic and lifelong, it is frustrating. But unfortunately, at this point, there's no distinction between the types of patients. And frankly, because we have always advocated and the law is clear that every case should be individualized and assessed, and there should be no rules of thumb in Medicare, that particular requirement of a new order for services every 60 days is something that hasn't been on the top of our priority list to change, but we certainly understand why that causes angst.
Okay, well, thank you very much.
Thank you, James. Let's try Robin K. Are you there, Robin?
I am unmuted, I believe.
Perfect.
Correct? Okay.
Yes, you are.
So I have a couple questions. I'll do my first one. That's probably the most important. We do have long-term care insurance. We have a daily limit. The facility fee for the facility will eat up most of our daily limit. Does that mean because we have long-term care insurance, even though we are on Medicare, my husband is on Medicare who has Parkinson's, that we cannot use some of these other services? In other words, does that disqualify me, or can I also get Medicare services at the facility?
I'm sorry, when you say facility?
Well, where he's going to be living.
Oh, like,
Okay.
is it an assisted living facility, or is it a nursing?
It's retirement / assisted living, and they're going to be providing some of the assisted living and some of the medicine management and other things. But what he also was going to need is some other things. And my question was, this is new for us. We're moving to this facility, and the long-term care insurance, which is what we've been using currently to pay for his therapy services, will now be taken up, most of it, by the facility fee of where he's going, because now he's moving into a place. So my question is, does that have any effect on whether we can still use any Medicare services?
Yeah, go ahead, Wey-Wey.
Well,
So it might impact whether or not he can get home health services in that facility. And I think you should talk to maybe a social worker or other administrator at that facility to see whether being in that facility means that, you know, home health services through Medicare cannot be provided or would be significantly limited.
So ask the facility. Here's my problem. It's a brand new facility. It's opening up March 1st. They're going to have so many things going on. My question is, does having long-term care insurance disqualify you for having automatically for having Medicare? It sounds like the answer is no.
No, the answer to that part is no. I think what Wey-Wey is trying to help determine, and if you look in the Medicare Benefit Policy Manual, Chapter 7, there's a section on assisted living facility.
Okay, hold on, I'm writing it down. The Medicare, what did you call it? The
Medicare Benefit Policy Manual,
Okay.
Chapter 7.
Okay.
And there's a section in that policy manual, and you can just Google it online.
Right.
There's a section in there on assisted living. And essentially what it says is if the facility is providing aid services, then Medicare won't also provide aid services. That's one part of your question, but read that section.
You're right.
It's very clear that there's another section in that same policy manual that gives an example that you can get 24, if you need 24/7 home health aides, Medicare would cover, excuse me, as long as you meet all the qualifying criteria, Medicare would cover up to 35 hours, and then you can supplement that with a long-term care policy or a different type of payment, either private payment or another type of insurance. It often kind of puzzles me why the long-term care insurance folks don't get a little bit more huffy about having to pay first for aids rather than saying, Medicare should cover these. But in any event, there's a very specific example in that policy manual that talks to the ability to use various payment sources in order to put this together.
It sounds to me like it's going to be an issue of who does the billing and who does it first. And my point was, this is a brand new facility. It's a new concept for this particular area. And if I don't know I need to be able to say to them, you need to do X, Y, Z, because I don't think they're going to know is what I'm getting at. And I want to make sure I get all the services I can for my husband. Specifically, he has a trainer and a physical therapist that comes in that only does Parkinson's therapy. I know they won't have that at the facility that he's going to. In my mind, that would be something that would qualify that's not being done. But again, how they bill it is going to be key, I guess. So I guess that's what I need to focus on. And thank you for your help. I appreciate it. One last question. When in the case example that you had in your presentation, you said that the agents, somebody educated the agency. Was that the Center for Medicare Advocacy? Was that your group, or who did that?
That was the patient. Very strong daughter of her father, and we provided them with the information to justify, the law, made sure that everybody was clear that this was not something that we were making up, that this came directly from Medicare, and that was what the family took forward to the agency to justify their request.
So basically, it was educating the family member who was trying to advocate for their family person, and then they're the ones that are responsible for going to the agency, and they just need to make sure they have the proper law or legal or the words, and that's what you gave them, correct?
Correct.
Got it. Thank you so much.
Thanks, Robin. Let's try. Sorry, Dana S. Are you there? Looks like you're self-muted. Dana S., can you click your microphone one time? There you go.
Okay, what about the Medicare Advantage plans often say that they provide additional in-home benefits like home-delivered meals. How is that really panning out in practice?
So that's a completely different benefit than the home health benefit. And frankly, what we're seeing on that is that it's kind of an a la carte. We'll offer you a few different options and you can choose. And some of those that we've heard about are things like home health aides that are available without going through the home health benefit. Frankly, Wey-Wey may have more experience with this, but rarely have I heard of a Medicare Advantage plan that puts this into practice. So I'm not sure how it's working, but supposedly that is one of the extra benefits. And you can choose if you want transportation or you want in-home meals. You don't necessarily get them all. It depends on the Medicare Advantage plan.
Thank you.
Yeah, we don't have a lot of information on how it's playing out, but yes, it is separate from what we've talked about today.
Thanks, Dana. You guys doing okay?
Yeah.
All right.
Happy to help if we can
There's
continue
still
to
a
answer
bunch
questions.
of hands. Beverly, have we gotten to Beverly yet? Beverly K, you are self-muted. One click on your microphone. There you go.
Okay, thank you very much. The person who spoke like persons ago, you were talking about a family member educating the agency. So I have a friend who has Parkinson's. Her physical therapy was discontinued. She's plateaued and all of that. So would the next step then be for her doctor to submit a plan of care or recommendation, and then that would go to a home care agency for the physical therapy? How would that actually play out step by step?
Wey-Wey, you want to take that one?
Sure. So yes, I think you should go to the physician and have them write an order for a physical therapy evaluation, and also specifically state in that order, to evaluate for possible maintenance therapy, whether this patient could benefit from maintenance therapy specifically, so that when they're doing the evaluation, they're not just looking at how much improvement can be made, but whether maintenance therapy is appropriate to try to maintain and preserve the patient's condition.
Now, I've done a lot of reading about the GMO agreement, and it seems to me that my friend clearly fits that criteria. So that would be and then the family presents that to a vendor, a home health agency, and hopefully try to convince them. What happens if they have trouble convincing an agency to get on board and continuing? I'm not worried about home health aides because she's got live-in aides and they're just doing it and it seems to be working to their benefit. But having the physical therapy, and later on I know they're going to discontinue the speech therapy, which she desperately needs. It would be the same thing. But right now they did stop the physical therapy.
Okay. Well, as Kathy had mentioned earlier, it's good to see if the physician, your husband's physician, knows about an agency, has worked with an agency, and referred patients to that agency. But it also sounds like he's getting speech therapy currently from an agency. So that might be the first place to go to, is the agency you're already working with.
Okay.
Yeah, and I would add to that, as Wey-Wey mentioned, it's important to focus on the fact that this is maintenance, because everyone who has an order for home health care is required to have goals. This is the goal, this is the expectation, and this is one of the reasons why the goals may change. And so this is one of the reasons why every 60 days you have a recertification. It's all about the goals. And one of the things that we have seen is if someone has, for instance, they may start out with an improvement goal and then move to a maintenance goal, you have to change the order and you have to change the goals, so that otherwise the claim may be denied. So it's important to recognize exactly what you're trying to accomplish, how many, and as much as, again, specificity as possible from the doctor in consultation with the patient and the family about what the need is, what the expectations are, what the goals are. And then when you call the agency to have them come do this assessment to put you into service, then you want to be able to at least say, this is, we discussed the goals with the doctor, we discussed what we want to happen. And a lot of times with maintenance goals, it is truly to maintain as much functioning as possible and to slow the deterioration of the condition. And those are legitimate goals. Those are the need for skilled services is there, and finding an agency may be a matter of then, calling many agencies. You may find one agency in one part of town that says we don't take patients that are not going to improve. You can't change their kind of structure. So, and frankly, if they do take you, they don't take you for very long. So then it's better to go on to the next agency, because agencies have different missions, and some agencies really get this idea of maintenance.
Okay, thank you so much. I really appreciate that.
Thank you, Beverly. We have Jennifer P. She's one of several people that wanted to go back to IHSS. She said, I can help explain what that is for folks who are interested. Jennifer, you are self-muted. Jennifer P. There you go. Thanks.
Hey, thanks. Before I say anything, I just want to acknowledge the work that you all bring to this, and I don't mean to overshadow it in any way by answering a question, because I really value the information that you provide. I am with a high cap in Alameda County in California. And so IHSS, at least in California, you have to qualify for Medi-Cal to qualify for IHSS. So it wouldn't be for skilled care, it would be for personal care. If that person qualifies for Medicare and Medi-Cal, Medicare should still be paying for anything Medicare is supposed to cover. And IHSS would be covering any of that personal care that's not covered by Medicare. And then there was another question about long-term care insurance. And I also have training in that as part of our high cap, and just wanted to add that long-term care insurance should also be covering personal care. And that can cover it in an at-home setting or in a skilled care setting. But Medicare, if the person has Medicare, Medicare is still responsible for meeting all of the things it's supposed to provide. And it shouldn't kick that over to the long-term care insurance, because the long-term care insurance is meant to provide the personal care. So I just wanted to add those. But again, not to step on any toes, I really value everything you guys teach us.
Thank you. And you teach us as well, and we appreciate the partnerships.
Thanks very much, Jennifer. Let's see. Back to Benny's maybe. Wallace R. Are you there? Wallace R. If you could click your microphone. Perfect.
Yes, I haven't heard any discussion about the Alzheimer patient and what might qualify as a skilled nursing requirement. I have a patient who's 5 years into dementia, and the needs are getting greater as we go along, but I didn't see anything specifically in the need that would require skilled nursing care except a mental evaluation of the patient.
Wey-Wey, can you?
Well, this is difficult to speak to because there's so much variation among dementia patients, but it sounds like from what you just said that you're starting to see some issues arise, and they could definitely begin to have issues around swallowing and behavioral as well. And also, risks from aspiration and so forth, and also infections. So I think, having a good relationship, again, the treating physician might be very key to helping determine what kind of skilled services might be beneficial for an Alzheimer patient, depending on the stage they're in and what symptoms they're showing. So.
Thank you for all your help and the good work you guys are doing.
Thank you, Wallace. Let's try Daniel. Daniel R. Are you there? One click on your mic. And maybe not. We'll move on for now. Emily L., your hand's been up for a while. Are you there? There we go.
I am here. Hello. Thank you both so much. This has been really informative, very helpful. My husband has ALS, and I think we're kind of almost identical to the case that you presented before. We've only been able to get skilled care, not any aid care. We were just told no. I asked his agency if I could get a copy of their plan of care, and they told me that that doesn't exist. The only thing that they could provide me with is a list of visits for. So what can I say to them now, or who could I ask?
Yeah, how long have you been with this particular agency, if you don't mind my asking?
No, not at all. Well, he used them 2 years ago, and then they just charged him within about 5 weeks, and just told us, "Hey, we've wrapped up. We're not going to see you anymore." And his muscle spasticity got so bad that we asked his nurse practitioner if he could get another order, and so it looks like that they've done it this time too. They just told us today that they're wrapping up with us at the 4 to 5 week mark.
Even though that the nurse practitioner does not agree with the discharge?
She will probably just go along with the discharge. We asked both the agency and her about aid care, and we were told no from both of them, that the most that they would possibly consider doing was just a bath, which would take an hour once a week, but they don't offer any other services for us.
So one of the things that we realized from the survey that we did, that we sent out to everybody, was that, again, you call different agencies and you're going to get different answers, and it can be based on what they feel they should provide, knowing what the situation is. It could be there's a staffing problem that's temporary. It's hard to know. So one of the things that we suggest to people is you do try to contact, as we did, just call the agencies and tell them that you have an order for service. And the reason I'm saying kind of move on at this point is that if you have an agency who you're going to have to fight tooth and nail every time you want to keep somebody on service, it's probably not an agency that's going to be anything but a headache over the long term. So so you might want to look and see what other options are available. One of the things we have further down in our resources list here is, sometimes you don't want the perfect to be the enemy of the good, and sometimes you just have to say, I can't get everything that we want, but if I can survey a number of agencies and see what's out there and what's available, try to do that. The other thing, which seems really counterintuitive, is when you look at that care compare tool that I described on Medicare.gov, where you can put in your zip code and look at the information about agencies. If you see an agency that has a 5-star quality rating, it mostly means that they're only taking patients who can improve, because that's how they earn their 5 stars, is based on improvement criteria. And so while it does sound counterintuitive, I would say, as you're looking through a list of agencies that serve your zip code, maybe don't pick one that has a 5-star quality rating, and maybe try some of the nonprofit agencies, because they may have different missions. That's being very general, but if you're trying to kind of narrow down your options on who to call, but I personally, because I made a number of the calls that were in the survey, and I was shocked at the differences in the amount of services that different agencies were able and willing to offer. So I would suggest you put in that particular time up front to find an agency who understands, and ask them, quiz them, like, have you served patients with ALS before? Do you know what's involved? Do you understand what's necessary for an ALS patient? You'd be surprised how many agencies will say, well, no, we don't really do that. And that's when you say, thank you for your information, and move on. But those are just some ideas.
Great. Thank you very much.
Thanks, Emily. Good luck. It looks like Daniel, I think, has unmuted himself. Daniel. And you've remuted. There you go.
Hello, can you hear me now?
Yes, sir.
Can you hear me?
Yes, sir.
Oh, good. Hi. Oh, first of all, again, thank you, Matthew, Kathy, and Wey-Wey for a wonderful, wonderful presentation. This has been so informative. I know thousands of people are grateful for it too. Yeah, my question is quite simple. Oh, by the way, I happen to be a Parkinson's patient myself. I've just been diagnosed, so this has very personal interest to me, what I'm listening to. Can you give us some, just a few examples of situations that are clearly not covered by Medicare for home health care? Because believe me, there's been some confusion. I understand if it's 24/7 care, okay, that's not covered. But there are other situations that clearly would not be covered. And I think that would be helpful too. And then I have one more question. If we want the Center for Medicare Advocacy on the case, how do we get you on the case? Okay, just those two questions. Thank you.
Well, the first question is maybe a little easier to answer.
Okay.
Sorry, I've got a little bit of an echo there. I would say that the main reason why someone would not qualify for home health care is that they don't need a skilled service. So if you don't need and you're not homebound. So for instance, if you can get to your doctor's office without a taxing effort, without all of those criteria that Wey-Wey went through, and you don't and you need assistance, just custodial assistance. I don't mean just as in that's, I'm not putting any weight on it, but if you don't need a skilled service at home because you're homebound, those are the hoops that you typically go through in order to get the care. So you need an order for services. You need to be homebound, as Wey-Wey described it, and you need a skilled service. And if any of those criteria are not met, then that's a problem. And then the only other thing that I can think of, frankly, about that piece is if you are really not considered living in a home. So if you're in a skilled nursing facility or you're in a hospital, then the two benefits don't kind of, you don't get both, so to speak. As far as you getting help from the Center for Medicare Advocacy, again, home health is one of our priorities, frankly. So we don't help people find agencies, but certainly if you are running into access problems, if you're not getting the services that you need, we want to hear about it. We want to know what people are experiencing, and if there's any advice that we can give or resources that we can offer, because we've been doing this for a while and have heard a lot of, we totally value the information and the questions and the discussion that come from people who are trying to get those services, because this is the only way we're going to fix this disconnect, this problem, is through hearing from patients who are not able to get the services that they legally qualify for. People often say to us, why aren't you fighting for more? We're like, we're fighting for what's already legally covered at this point. Let's get that in place and then try to expand the issue. But this is a law. This is something that Congress has supported and intended, and we're here to try to make sure that gets fixed.
Thanks so much. Thanks for that explanation, Kathy. We're now over half an hour late to end. I understand that. We still have almost 400 people on with us, half an hour late. And I want to thank you all for hanging out. I want to say again, for those of you that have your hand up, I would definitely write those questions in. I think we're going to have to wrap up here. So please type those in. I won't shut things down just yet. We'll say some closing remarks. Kathy, we did have a couple questions. Could you mention again the website to go on and compare home health agencies?
Yes, it's Medicare.gov. It's the official Medicare website. And if you put in the search little bar there, if you put care, compare, or even home health compare, you're going to get, it will bring up the, I wish I could do it right now, but I'm not that technically astute. It will, and then I could show you, but you can bring up.
You can just bring it up on your screen where the presentation is right now.
Yeah, I could do that if I could navigate everything, but
Okay.
let's just say Medicare.gov, put care compare in the tool, in the search bar, and then you'll see it'll list in circle, there'll be circles that say hospital. So if you're trying to compare hospitals, for instance, in nursing homes and home health, and then if you click on the home health button, and then put in your zip code, it will prompt you to say, what zip code are you looking for? You put in the zip code and it will show you every Medicare certified home health agency. And it will within each one of those agencies, there's information, as I mentioned, about there's a patient satisfaction rating. We always look at those. There's a quality rating. Sometimes if you're looking for something where you're not going to improve, you want to not go for a 5-star. There's information about how long has the home health agency been in business. Are they for profit? Are they not for profit? There's information about the types of discipline services that they offer. Do they all offer home health aides? Do they offer nursing and physical therapy, occupational therapy, speech therapy, medical social services? What are their services that they offer? So you can pick up at least a small amount of information just from looking at that care compare tool.
Thank you very much. Perfect. All right, folks. Kathy, Wey, do you have any last comments? Any last encouraging words?
Sarah, I'm tremendously grateful for everybody for joining us. We are by no means done with this conversation. This is a conversation that will continue. We really appreciate your feedback. We appreciate hearing your stories. We appreciate knowing if you're having difficulty accessing the services. And as much as it seems like you're talking into a black hole, if you can't get services, I think it's so important to report that to Medicare. Let them know that you're not getting the services that you need. One of our biggest concerns about this what we're discovering is if you can't get your foot in the door to get services, then you don't get counted. So Medicare thinks, we're providing services to people. But if you're a segment of the population that can't get the services that you need, you're not being counted. And so you're not in the data. And that's a big problem. And we need to make sure that somehow the people who aren't getting access to care get heard. And so we want to hear from you. We know that Medicare wants to hear from you. We happen to have a meeting on Monday with the Medicare director, and we talked about our survey results, and we talked about all of the problems we see with the policies and the practices, and we want this to be fixed. And it's not going to get fixed overnight, but the more that we collectively do what we're doing right now and have a conversation and discussion about it, and the more that we get to hear from you, we really appreciate that opportunity. There's more advocacy tools and practical tips in the materials past this discussion slide, and ways to contact us, and additional resources on our website. And thank you.
Thank you, Kathy. Thank you, Wey. Thank you all for attending today. Especially thank you for hanging out all this extra time and for the great questions that you asked. As noted, there are some more materials in the slides. We are recording this presentation. We're going to have it posted. It should be up by the end of the week, and we'll send an email with a follow-up link to everybody that attended. Speaking of webinars, We have another one coming up January 27th, sponsored by California Health Advocates. That'll feature a little Medicare fraud update, an update on audiology care, and other Medicare and healthcare updates. You can register for that now at medicareadvocacy.org. I want to thank everyone once again, and I will now officially, finally end today's presentation.